We're going to take a look at pain in this lecture. So why is pain important? We have pain to actually protect us. So if you start to do something that is damaging to the tissues, you start to feel pain, and then you will stop doing whatever it is, and then that will prevent further damage. So for example, if you start to touch something hot on the stove, it's going to become painful, and then you're going to withdraw your hand, and then that's going to prevent you from burning yourself further and doing more tissue damage. And then the next question, does pain perception vary among individuals? So if you've worked in hospitals or clinics or just looking at your family and friends, you've probably answered yes to that question. So you probably know some people that seem to have a very high pain tolerance, and they seem like they're pretty stoic and can take a lot of pain. And then there's other people that seem to have a very low pain tolerance and show a lot of pain, at something that someone else, wouldn't bother them. And then we all know that pain does differ under different circumstances. So a good example of this would be maybe you've got a toothache, but you've been busy at work all day and you don't really notice that your tooth really hurts. But then you come home and now you're getting ready for bed and you lay down in bed and now you realize that, oh, my tooth really hurts pretty bad. And that's because you're no longer busy, you're not thinking about other things, and now you can concentrate on how bad your tooth hurts. Okay, so different circumstances can affect how much pain you feel as well. So the pain response is going to stimulate pain and also a couple of other things. So it does stimulate the autonomic nervous system. It stimulates the sympathetic division. So sympathetic division is fight or flight. So pain response, you also will see an increase in heart rate and blood pressure. And then pain is also going to stimulate some emotional responses. So you become fearful and anxious. So you might have seen that in some of your patients if you're working in hospitals. And then also it stimulates the withdrawal reflex. So like if you start to burn your hand on the stove, that'll stimulate that withdrawal reflex to pull your hand away. So we actually have two different types of pain. We have fast pain and slow pain. And the reason we have these two different types of pain is because of the different types of axons or nerve fibers that are carrying the pain signals up to the brain. So we've got the A delta fibers and the C fibers. So these would be really important to know, the difference between the fast pain and the slow pain. So the A delta fibers, they're going to be larger diameter than the C fibers, and they also are myelinated, whereas the C fibers are not myelinated. So the A delta fibers are going to be able to transmit the action potentials at a much faster speed than the C fibers will. So that's why we have fast pain, because the A delta fibers will get the pain signals up to the brain a lot faster than the C fibers do. So that's why the C fibers give you the slow pain, because they're going to transmit those pain signals a lot slower. And the characteristics of the pain of fast pain and slow pain are a bit different as well. So fast pain is going to be more of a sharp kind of pricking sensation, and it's going to be pretty easy to localize and know exactly where you hurt. Whereas slow pain is going to be more of a dull, aching sensation, and it's going to be harder to localize exactly where it hurts. It's kind of a broader area. So a good example of fast pain and slow pain would be maybe you stubbed your toe really hard. And so that immediate pain that you get when you first stub your toe, it's a very sharp pain and it's really easy to localize, you're like, yep, my big toe really hurts. That first immediate pain that you're feeling, that's going to be that fast pain. Okay, so you can see on this graph over here on the right, that fast pain is what you're going to feel at first when you stub your toe, and those pain signals get up to your brain first because they're being transmitted on those A delta fibers, which are larger in diameter and myelinated axons. But then a couple seconds later, you're going to get hit with another wave of pain, and that's going to be your slow pain. So then it just seems like the pain changes, and it's more of this dull, aching, kind of throbbing pain, and it spreads out. So now it's not just your big toe that hurts. Maybe now it's your whole foot that hurts. Okay, so it'll be more poorly localized. And so this is going to be the slow pain that you're now experiencing. So you can see that on the graph, the slow pain that comes second. And it's just because the C fibers took longer to transmit the slow pain signals up to your brain. So they got up there a little bit slower. Okay, we also have another type of pain called visceral pain. And remember, the viscera are your internal organs. So visceral pain comes from your internal organs. Your viscera, your internal organs, are going to be innervated by C fibers. So is visceral pain going to be feeling like fast pain or slow pain if your viscera are innervated by C fibers? So hopefully you said that visceral pain is going to be slow pain. Okay, so if you've ever had like a stomach ache, it's more of a dull, aching type of pain, and it's kind of hard to localize exactly where it hurts. It's just somewhere in the stomach area, and you don't know exactly where the pain's coming from. And the other thing that makes visceral pain hard to localize as well is that visceral pain will also produce this referred pain. And this is where the pain gets referred to the body surface up to the skin. So let's see how this works. So this is really interesting. And this just has to do with how the wiring is in the spinal cord. So we've got the sensory neurons that are picking up signals from the cardiac muscle, and they're going to travel up through the dorsal root of the spinal nerve into the dorsal horn of the spinal cord here. And so this would be this first order sensory neuron here coming from the heart muscle. And then we also have these sensory neurons that are coming from the skin, and they're also going to be synapsing on the same second order neuron going up to the thalamus. So when you have signals coming in like from a heart attack, so you're going to have some pain signals because the heart muscle didn't get enough blood and it's dying. So you got some inflammation, some pain coming from there. And this second order neuron taking that pain signal up to your cerebral cortex says, well, who's that coming from? Is that pain signal coming from the skin, or is that coming from the heart muscle? Because both the heart muscle and the skin, those sensory neurons, are both converging, they're both meeting on that same second order neuron to go up to the brain. And so the brain says, well, you know, kind of playing the odds here, most of the time I'm getting sensory information from the skin. So it's probably from the skin. So that's what the brain interprets where the pain is coming from. And so you're going to refer the pain from the heart attack and think that it's actually coming from the skin when it's actually coming from the heart. So that's why people will complain that when they're having a heart attack, instead of saying, oh, my heart hurts, they might say that, oh, my left upper arm hurts instead. Okay, because this pain from your heart muscle is being referred to the left upper arm. Okay, so that's what referred pain is. So that's pretty interesting. Okay, we can also modulate or modify pain signals. So the body can decrease pain signals to the brain, and that's called analgesia. So an means without, and algesia means pain. And there's two ways to do that. We'll talk about the gate control theory, and we've actually already learned about this endogenous analgesia system. We call it the descending analgesia system, so same thing. And the other thing that the body can do is it can increase pain signals to the brain, and that's called hyperalgesia. So hyper meaning an increase or excessive, and then algesia is talking about pain. We definitely don't want hyperalgesia to be occurring because that makes something painful feel even more painful, but it can occur. We can see that, for example, when somebody is depressed or anxious, painful stimuli will actually feel more painful to that person. And then also people with chronic pain. There's some changes that happen in the spinal cord, something called wind up that you'll learn about in your nursing classes, that will make chronic pain more painful. So that's not so good either. But let's take a look at decreasing pain signals to the brain with analgesia. All right, so let's take a look at this gate control theory. This is really interesting. So, like when you were little and maybe you fell down and scraped your knee and your mom told you to rub your knee and that'll make it feel better. Well, that actually does work. So rubbing your knee or a sore area actually will make it feel better. And why that is because of this gate control theory. And this is also why TENS units work as well. TENS units are used in physical therapy where they apply little electrodes to your skin and kind of zap you with some electricity, and that stimulates some of the sensory neurons in your skin, and that also activates this gate control theory idea as well. So, all right, so what is this gate control theory? So on the left, let's say we fell down, scraped your knee, and on the left we are not rubbing our knee yet, okay? So we have our gate open and we're just letting the pain signals from our scraped knee just go right up to the brain. Okay, so we've got our nociceptors picking up the pain signals from the damaged skin, from the scrape on our knee, and we're just transmitting that up to the spinal cord. So this is our first order neuron, and then we're synapsing here in our spinal cord, second order neuron, and we'll just let that pain signal go all the way up to the brain, and yeah, our knee hurts. Okay, and then over on the right, we've got our gate control theory. So what we're going to do is we're going to start closing the gate, and we're going to start blocking that pain signal from going up to the brain, and that'll make our knee hurt less. So if you rub your knee, why it makes your knee hurt less is that if you stimulate those touch receptors in your knee, okay, these sensory receptors for touch have some collateral axons that will synapse with some interneurons in the spinal cord, and these interneurons are inhibitory to these secondary neurons that are the second order neurons that are carrying pain signals up to the brain. Okay, so here's this first order neuron that's coming in from your knee, bringing those pain signals, synapsing with the second order neuron in the spinal cord. and it's going to be creating an EPSP. Okay, so it would be creating a depolarizing graded potential in this second order neuron, but this skin touch sensory neuron that's synapsing with this inhibitory interneuron is creating an IPSP in this second order neuron. And so these can cancel each other out, and you can decrease the pain signals going up to the brain. And that's why rubbing your knee will make your knee feel better. Okay, so it actually does decrease the pain signals going up to the brain. So you end up, kind of closing this gate here on the pain signals, blocking some of those pain signals from going up to the brain, and then it doesn't hurt as much. So that's the gate control theory. So that's pretty interesting. Okay, and then we have this endogenous analgesia system or descending analgesia system. So this is where we have these descending pathways from the brain to the spinal cord that can block pain signals from going up to the brain. And let's just take a look at this. So we've got, maybe we're under a lot of stress. Like we talked about the soldier in battle, maybe they got shot in the leg, but they've got to keep fighting in order to stay alive. So we've got that stress there. We've activated this descending analgesia system that's in purple here, and we've got these neurons coming down the spinal cord. And here we've got some sensory receptors coming in from the periphery. We've got this first order neuron. We've maybe stepped on a nail here. And we're going to synapse here on the spinal cord, and then we're just kind of taking a close-up view of this area here on the spinal cord right here. Okay, and what we want to do is, with these purple neurons that are making up this endogenous or descending analgesia system, we want to block these pain signals that are being sent up to the brain. Okay. And that word endogenous just means that it's coming from inside your body. Okay, so we're able to decrease the pain inside your body without any outside help. Okay, so a couple things go on. So these purple neurons coming down from your brain are going to synapse with this inner neuron in the spinal cord. And we've got a couple of things going on here. So one is we've got an axo-axonic synapse between this inner neuron and then this first order neuron coming in from your foot. And remember, these axo-axonic synapses, they're going to affect how much neurotransmitter is released. So we've got presynaptic inhibition going on here. So this neurotransmitter released from the green inner neuron is going to decrease the amount of neurotransmitter released from this blue first order neuron. And then that means you won't produce as big of graded potentials in the second order neuron, and then you may not reach threshold and then send the signals on up to the brain. And then the other thing going on is this neurotransmitter enkephalin that's being released here in both places. Enkephalin is a natural opioid that we actually produce. And this enkephalin will also produce some IPSPs, some hyperpolarizing graded potentials in the second order neuron as well. So that will also inhibit the second order neuron from reaching threshold and producing action potentials and sending the pain signal up to the brain. So all of that will block the pain signal going up to the brain. And then this is just a close-up view, just showing you the axo-axonic synapse that we looked at this picture before with the enkephalin being released, and that will decrease the amount of neurotransmitter being released here, and then we don't reach threshold and send the signal on up to the brain.